Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Stephen Newmark, Chief Policy Officer at the Global Healthy Living Foundation. Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life. Today, I'm joined by someone who has lived through and shaped healthcare in ways few people can claim. Cynthia Overton is a nationally recognized leader in person-centered care, the founder of her own consultancy, and a passionate advocate whose 25 years of experience navigating our health system began with her own serious illness. Cynthia, welcome to the show.
Thank you so much for having me, Stephen. It's really great to be here.
Yeah, it's great to have you. Let's start with your story. You spent 7 weeks across 3 hospitals and then years navigating the system. How did that experience push you toward making person-centered care your life's work?
So I got to tell you, Stephen, it was definitely a process. So back in 1997, I had surgery to remove something called an arterial venous malformation from my spinal cord. We didn't have the medical advancements back then that we have today. So at first, my focus was just purely on surviving. Then after the surgery, my focus really shifted to recovery. And we all know that recovery looks different for everyone. It doesn't always mean going back to the way things used to be. And that's okay. For me, recovery meant living without this AVM, that's short for arterial vascular malformation, and then also learning how to walk again with a cane. So once I got to that point, I had to focus on rebuilding my new life. And for me, that meant, experiencing the world through a lens of somebody with reduced mobility. And I wanted to make the world more accessible. And so at that point, I really started working on, I went back to school, got a few degrees, and I started working on research and policy projects around accessibility, just to make things easier for people with disabilities, right, like myself. That work then led to creating patient education materials through a project called the Model Systems Knowledge Translation Center, and then most recently writing a book, Clear Cane Chronicles, that really focuses on person-centered care for patients, providers, and payers.
Fascinating. Well, when you tell your story today, what's the one moment that really captures the gap between how patients experience care versus how the system expects care to be delivered?
That's a really good question. And so with me, I was really fortunate to have access to healthcare and to a really strong team and diagnostic tools to find this AVM in my spinal cord. But what I didn't have access to, Stephen, was a doctor that was experienced in spinal cord surgery. The doctor that diagnosed me only did 4 of these procedures a year. The most experienced neurosurgeon in the state where I was living at the time only did 10 a year. So keep in mind, the spinal cord is massive. It controls your walking, how you perceive pain, how you regulate temperature, your bowel and bladder functioning. And I always say, its reach is massive. If Beyonce was a body part, she would be a spinal cord. So 4 or 10 surgeries a year, it just didn't feel right. I mean, my family and I wanted someone more experienced. And we found Dr. Epstein, who was a world-renowned surgeon in New York, who had actually developed techniques to operate on spinal cord conditions that were just once considered inoperable. But the issue, Stephen, is he was out of network, and the health insurance company was only willing to pay for an in-network doctor. So my family and I were in this situation of having access to treatment that was covered by insurance with a lower probability of a successful outcome. I wanted the best chance for a positive outcome. So my family went back and forth with the insurance company to get them to pay for the operation, but they also had to explore personal financing. So as it turns out, the morning that my mother was going to go to the bank to do the paperwork for a loan against our home to pay for this specialist to do the surgery, my insurance company called and said that they would pay.
Wow. Well, it's a story we've heard before, but it never gets old, I guess. Let me ask you, just switching gears a little bit, person-centered care. That's a term that gets thrown around a lot. It's a buzzword. But what does it actually mean to you, and how is it different from the traditional clinical model most of us know?
Yeah, and you're absolutely right. I'm so glad that you asked this question. So let me kind of just start off first with traditional clinical care. And that's care that's provider driven. Your doctors, they diagnose you, they give you a treatment plan. Then you've got patient centered care. And people often, even I use the terms interchangeably sometimes, not meaning to. People confuse patient centered care with person centered care. But patient centered care is more collaborative. Doctors, they consider your preferences and they consider those as they come up with treatment plans for you. But person-centered care takes us even further by considering individuals' goals, their relationships, the environments, their beliefs. This approach really addresses the whole person within the context of their life, and the patient is a partner in care with their provider. And I kind of think about it like with the evolution of television. Traditional clinical care is like old school network TV. One size fits all, you take it or leave it. Then patient-centered care, I kind of think about like when we got cable. We had more choices, but we still were constrained by this systems-driven schedule. Person-centered care, I kind of think of as like the streaming era. It's personalized, on-demand, responsive. You log in, the system knows you, and it supports your choice in what to watch. So that's kind of how I think about the differences in the types of healthcare delivery.
Interesting. And what kind of obstacles do health systems run into when they try to embed that model?
I would love to see patients, providers, and payers actually be more intentional about person-centered care. As patients, we come with these real concerns. We're concerned about our health, but we're also concerned about how our health is impacting our families, our ability to work, or even just our ability to be comfortable. We want providers to really understand our needs, understand our preferences. We want the best options available. But a lot of us, Stephen, have really been conditioned to stay silent, speak only when asked, follow orders from a doctor who has the important medical training and experience that we need, but who might not necessarily understand the context in which we're living and how a recommendation might impact the life of a patient. As patients, we want to be seen as people, not as cases. I always say we live in the real world and not in a medical chart. On the provider side, doctors went into this field to help people. They want people to heal and be healthy. But they're oftentimes working within these systems that create barriers, like tight schedules, heavy caseloads, insurance constraints, even basic human limits like getting enough sleep, stopping to eat, going to the bathroom. So doctors are often bound by these systems that we as patients just don't always understand. And then there's the payers or the insurance companies. There's a lot of broken trust there. And that's not something that a media campaign can fix. The red tape, confusion patients experience, they're real. But here's the thing, two things can be true at once. There are also people within these companies who genuinely want to help. So we've got to try to figure out how to find those people, establish relationships, tap into them for insights and advice. And we need those folks to stay motivated, which I can only imagine is really difficult when you're caught in the middle between members who have real urgent life or death needs and decisions from higher ups. And that's why it's really encouraging to see some insurance companies making these voluntary commitments to improve transparency, streamline communication, and even expand access to mental health and preventative care. But we know that this is voluntary. These commitments are voluntary. So it's really important for us as patients and even providers, those who are providers, to hold these insurance companies accountable for these voluntary commitments.
When you think about value-based or accountable care models, can person-centered practices actually fit without overburdening clinicians?
Oh, 110% they absolutely fit, especially when we think about kind of like existing assets. So take family and caregiver support. It's often undercultivated and underutilized, but it is essential to person-centered care. So when I was 26 and recovering from spinal cord surgery, my parents, they were still helicopter parents. They're even helicopter parents today, to tell you the truth. My healthcare team engaged with them. They answered questions very thoroughly. They trained them on how to help with my recovery. It took a little extra time up front, but it saved them time in the long run. My rehabilitation team, when I was paralyzed, they essentially deputized my parents. They were able to help out in some instances where staff weren't able to because these providers took the time to train my parents on how to safely assist me. In fact, my father would come after work and just kind of help me walk up and down the halls with a gated belt holding on to me just to try to rebuild my strength. But because of the small time investment that these providers made, we all felt very confident in my recovery. Because of that, I was able to go home for a few hours to celebrate Christmas with my family over dinner. It was just a huge morale boost. So that's kind of like what value-based care looks like in real life. Small investments of time and education, for me, improved my safety. It reduced risk of readmission, it built trust, and everybody was happy. We see this in value-based and accountability care models that improve provisions for caregivers, like assessments for caregivers during intake or discharge that help to identify issues and promote patient safety and to avoid rehospitalization. So these approaches align directly with person-centered care.
I mean, you mentioned hospital readmittance. What other metrics? How do you measure in terms of metrics? I mean, health systems love metrics. The stories, the anecdotes are great, but what's the right way to measure success in person-centered care?
I mean, I think the best way generally is to establish or identify systems in which metrics will actually be used and acted upon. When we think about kind of like a formal approach, there are a few validated tools for person-centered care, but most were created for specific settings like long-term or behavioral health. And when I say validated, I mean they've been scientifically tested and all that. But usually only focus on one perspective, and that is the perspective of the provider. I have developed, it has not been validated, I have developed 3 separate self-assessment tools, one for patients, one for providers, one for payers, so each group can really see and understand how their actions align with principles of person-centered care and think about opportunities to do things differently. And if any of your listeners are interested in those tools, they can just go to my website and drop me a note and I can send them to them. I would also really suggest that people turn to the picker principles for person-centered care and collaborate with their teams over those principles to take an honest look of where person-centered care is showing up and then opportunities for improvement. And then finally, I'll just say my book, Clear King Chronicles, Shaping the Future of Healthcare Through Person-Centered Care, has an appendices filled with recommendations for patients, providers, and payers. And so again, individuals and teams can use those as a tool for self-reflection.
Interesting. Well, you emphasize storytelling and humor in your work. How do these tools shift power dynamics between patients and providers to yield better health outcomes?
Storytelling helps providers and payers really see patients as real people, not just as cases. And it connects us emotionally in ways that data can't alone. And don't get me wrong, data are important, but it's those storytelling opportunities that really connect us. And that's what inspired me to write Clear King Chronicles. I wanted to show what person-centered care looks like through the eyes of a patient who's lived it, not just studied it. And to your question about humor plays a really big role in that. Laughter is both a social and a biological reflex. It's universal. Stephen, not even chocolate is a biological reflex. Laughter is. And that's powerful because it creates common ground. When people laugh together, anxiety eases, titles fade, and suddenly we're all just humans trying to figure out problems together.
Yeah, no, that's great. Why don't we end on your vision? If we can do this right, what do you want the U.S. health system to look like a decade from now?
Well, I want to start off, Stephen, by just acknowledging how complicated the healthcare system is. There are so many variables that influence how care is delivered. So all of that said, my vision, maybe it's a dream, is for a system that is efficient, empathetic, accessible, a system where patients, providers, and payers are really aligned around person-centered care, a system where patients, they don't have to fight for clarity, providers have the support, and that's so important, that the providers have the support that they need to deliver care that's both efficient and humane, and then payers, we need them to remove barriers to create a smoother and more connected healthcare experience. So to accelerate person-centered care, I just want to say it's really important that we refine these systems for efficiency. We design healthcare around real experiences, and we make empathy part of performance. And in many ways, it's really returning to the spirit of that part of the Hippocratic Oath about putting patients first.
Well, Cynthia, thank you for sharing your story, your insights, and your vision. For our listeners, you can learn more about Cynthia and her work at cynthiaoverton.com, and we will post in our show notes more information regarding Cynthia and all of her published works that you'll be able to find in our show notes. Thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you found this episode helpful, please leave us a rating or review and share it with someone who cares about healthcare policy. And be sure to follow us wherever you get your podcasts. You can find all of GHLF's podcasts at ghlf.org/listen. I'm Stephen Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.